Thank you, Tony. Thanks for the introduction. So I'm going to talk about some of the abstracts at the AASLD this year on hepatitis B. There are quite a few abstracts, and I've kind of narrowed it down to 4 that I think are particularly important. And in fact, 2 of them refer to a single topic that I think is really crucially important, both to primary care doctors, oncologists, and hepatologists. And that involves the diagnosis and management of hepatitis B reactivation in patients receiving chemotherapy. We have 2 abstracts I'd like to talk about today involving that subject. Quantitative hepatitis B surface antigen titers are now available. What role they play in management of hepatitis B patients is not clear. I'm going to present some data about how these can be used to manage our patients and why they're worthwhile to get this fairly inexpensive test. And then, of course, we're all concerned about the patients with hepatitis B who have severe fibrosis, likely to go on to need a liver transplant or develop liver cancer. And does any of our new treatments that are available, does it affect outcome? Can we really do something about our patients with severe liver disease and hepatitis B? So the first paper I'd like to discuss is entitled Reactivation of Hepatitis B Infection Among Patients with Liver Cancer, and comes from the MD Anderson Cancer Center in Houston, Texas. The goal of the paper was to describe the prevalence and predictors of hepatitis B screening and reactivation at a comprehensive cancer center. This is probably the largest comprehensive cancer center in the country. This was a retrospective cohort of patients from January 2004 to September 2007. They screened patients with simple tests. They looked at both surface antigen and anti-hepatitis B core antibody total. And reactivation in this study was defined as an ALT greater than 100 and or a bilirubin greater than 2.5 that developed while on therapy, or a positive DNA in patients who were previously undetectable for hepatitis B, or a DNA that was low prior to therapy but then went over 100,000 copies while on therapy. They treated a huge number of patients at the MD Anderson with chemotherapy, over 10,000 patients during this period of time, yet only 17% of them were screened for hepatitis B. And of that number, 151 of them, or 8% of the ones screened, were hepatitis B surface antigen positive and or hepatitis B core antibody positive. 34 of those patients, or a quarter of them, went on to develop decompensation of their liver disease. So patients who got chemotherapy who were surface antigen or core antibody positive, fully a quarter of them, or almost a quarter of them, went on to develop decompensation. Those who received prophylactic antivirals, only 9 of these patients, and those who received antivirals only after chemotherapy only represented 11. So only 20 of the 34 patients even received any therapy once they developed decompensation. Well, what happened to these patients? Well, in those patients who got the prophylaxis, only 22% of them died. Remember, these are all cancer patients, and we can expect a fairly high mortality. However, in the patients with treatment only after they developed decompensation, 72% of these patients died, and we can presume that a significant percentage of this is because of recurrent hepatitis B that went on to kill these patients. So the authors concluded that reactivation occurred in about 25% of patients with hepatitis B, and it really had severe consequences in terms of mortality. And that very few patients were screened, unfortunately. Only 17% of the patients at the MD Anderson Center were screened. Well, I want to turn to another cancer center on the other side of the country in New York City, in Sloan Kettering, who presented this data about entecavir is effective in preventing hepatitis B reactivation in cancer patients receiving chemotherapy. So the aim of their study was to report on the efficacy of using entecavir, one of the new antiviral agents that's effective against hepatitis B, in preventing reactivation in patients undergoing chemotherapy. So they're going to try and prevent these patients from developing severe consequences from their hepatitis B. So this was a prospective study of all patients who were begun on chemotherapy at the Sloan Kettering Memorial Hospital in New York between January 2009 and April 2011, and were screened for hepatitis B. So they didn't really look at the percentage who were screened, they just looked at the patients who were screened. So we could presume that they probably had about a similar amount of screening as they had at MD Anderson, which would be less than 20%. But having said that, these were the patients who were screened for hepatitis B. They included patients who were hepatitis B surface antigen with normal transaminases. If they had abnormal transaminases, I believe they were always treated with entecavir. So these patients were in the study, or they were looked into other types of therapy if they had abnormal transaminases. But these are patients who were just discovered to have surface antigen, who wouldn't have been discovered if we were screening with just transaminases. All patients who were surface antigen positive were treated with entecavir, the standard dose of 0.5 milligrams PO a day at the start of chemotherapy, and it was stopped 6 months after chemotherapy. Important that the prophylaxis has to be continued for 6 months after the chemotherapy, because it's the reactivation of the hepatitis B and then the immune response with the immune reconstitution that leads to the severe illness. So this has to be continued for 6 months after the patient has already discontinued their chemotherapy. Patients were followed with 3-month ALT levels and hepatitis B viral DNAs. So of this group, 33 patients were found to be hepatitis B surface antigen positive. The DNA was over 1,000 in 12 of 33, so most of them had inactive disease, which is important because even patients with inactive disease can get severe recurrence afterwards. Only one case of reactivation occurred, so this is in patients given prophylaxis. Only one of the patients developed reactivation, and in fact, that patient who developed reactivation stopped his entecavir on his own and then became negative again when he was restarted on tenofovir after the virus turned positive. So these authors' conclusion from this paper was that entecavir was highly effective in preventing reactivation of hepatitis B in patients undergoing chemotherapy. So what are some conclusions that we can make from these two important papers that were presented at the AASLD meeting? Well, first of all patients undergoing chemotherapy, I think, should be screened for hepatitis B. It's very simple to do. It's an inexpensive test, and it has, absolutely incredible consequences to these patients if they develop reactivation. I think from the Sloan Kettering paper that entecavir is shown to be effective in preventing this potentially lethal reactivation in those found to be surface antigen positive. So certainly all patients undergoing chemotherapy who are surface antigen positive should be treated with a nucleoside or nucleotide analog to suppress the virus from coming back. I'm not sure that entecavir is the only drug that can be used, but certainly it was effective in the Sloan Kettering study. I think we really need to make our oncology colleagues aware of this important information. Even at the MD Anderson Center, only 17% of patients were screened for hepatitis B. Again, simple to do, inexpensive, and potentially lethal consequences to these patients who are not screened. Okay, so let's turn to a different subject now, and that's the use of quantitative hepatitis B surface antigen levels are significant independent predictors of hepatitis B viral DNA and surface antigen clearance in hepatitis B carriers, chronic carriers. So quantitative hepatitis B surface antigen levels are now available and readily available for testing. You can send them off. And what role they play in defining the natural history of hepatitis B is really unclear, and kind of how we can use this new test is in need of some validating studies. So the aim of this study from Taiwan was to look at the association between quantitative hepatitis B surface antigen levels and spontaneous loss of hepatitis B e antigen. Hepatitis B viral DNA and hepatitis B surface antigen loss was also looked at in untreated patients. So these patients were not given any therapy. They were just followed prospectively over time, and they looked at e antigen, DNA, and surface antigen. So in this Chinese cohort, 3,466 patients with hepatitis B surface antigen without cirrhosis were followed. I think that they felt that the patients who had cirrhosis would need to be treated, and so they were excluded from this follow-up study. All patients had quantitative hepatitis B surface antigen levels measured at their baseline. Hepatitis B surface antigen levels did predict clearance of surface antigen and DNA, but interestingly did not predict E antigen clearance. Maybe some of these patients were pre-core mutants and didn't have E antigen, and that's why E antigen clearance was not predicted. Certainly the two most important things that we look for in terms of clearance are surface antigen and DNA. So with patients with surface antigen levels over 10,000 international units, the clearance rate was very low. Only 3.2% of these patients cleared surface antigen. But in those patients with very low titers of surface antigen, less than 10 international units, a fully 85% of these patients spontaneously cleared the virus in these patients who are chronically infected. So the authors concluded that hepatitis B surface antigen levels can play a role in predicting clearance of hepatitis B viral DNA and surface antigen. I think that's a realistic conclusion. Hepatitis B surface antigen levels may be a good way to predict who will eventually clear the virus and probably not need to be treated with nucleoside or nucleotide analogs. So if we see a patient who comes to see us who has low surface antigen levels, we probably can just follow those patients and just watch and see what happens over the next year or two. If they have very high levels, then we probably need to consider putting them on nucleotide or nucleoside analogs, depending on the severity of their liver disease, of course. The last paper I'd like to talk about comes from the European Hepatitis Network and was abstract number 240 and was titled Virologic Response to Entecavir is Associated with a Lower Probability of Disease Progression. So as background, patients with severe fibrosis and active hepatitis B can have their hepatitis B suppressed with multiple drugs nowadays. Whether this suppression is associated with improved outcomes is still unclear. So we know we can suppress the hepatitis B, but is that going to make a difference for our patients in the long run? So the aim of this European Center study was to investigate the effects of entecavir on event-free survival in patients with hepatitis B infected who were infected with hepatitis B. So they looked at a very broad population at 10 European centers who provided data, and they were looking at one drug in particular, that's entecavir. And they looked at a complete viral response, which was making the hepatitis B viral DNA essentially undetectable, less than 80 international units per mil. And their clinical endpoints were development of decompensation, or development of hepatocellular carcinoma, or death. The results, they had 377 patients at these trans-European centers. 133 of them had advanced liver disease, so the majority of them did not have advanced liver disease. And fully 10 of them, or 8%, had decompensated liver disease at their baseline when they were started on medication. What happened to these 377 patients? Well, the ones who weren't decompensated, obviously, 6 went on to develop decompensation, 4 developed hepatocellular carcinoma, and 8 patients went on to die of liver failure. The mean follow-up was 19 months in this fairly short study that will be ongoing. So what they concluded was that patients with complete virologic response had a hazard ratio of only 0.2 of developing one of the events that they were looked at, decompensation, hepatocellular carcinoma, or dying. So a markedly decreased rate of progression to one of the end-stage events in those patients who responded to the entecavir. So the authors concluded that patients who show progression to hepatitis B, in patients who show suppression of hepatitis B on entecavir, improve the probability of event-free survival. So I think it makes a lot of sense to suppress hepatitis B in these patients. It's fairly easy to do. It's fairly cost-effective, although these new medications, the ones with low resistance profiles, are fairly expensive. But I think it does make sense to suppress it in these patients to prevent progression of disease. Though on the other hand, in this study, it's not clear that those who did not fully suppress were sicker to begin with, and that's why they had poorer survivals. So I'm not sure we can completely conclude based on this paper that survivals are improved by suppression. Though I think it's reasonable to think that that's true. I'm not sure that these weren't just two different patient populations. So to summarize the papers I presented this morning, despite the fact that hepatitis B reactivation is a serious problem in patients undergoing chemotherapy, few patients are screened for hepatitis B. Reactivation of hepatitis B can be easily prevented if discovered prior to the institution of chemotherapy and starting one of these patients on a nucleoside or nucleotide inhibitor. Hepatitis B surface antigen is useful in predicting spontaneous clearance of hepatitis B, and I think should be used in these patients, and especially if a patient we want to follow without treating them, I would want to know what their surface antigen quantitative level is to know what their chances are of spontaneously seroconverting. In response to entecavir can predict a favorable outcome in patients with hepatitis B and severe fibrosis. And I think certainly all of our patients with severe fibrosis and cirrhosis should have suppression of their hepatitis B done with one of the nucleoside or nucleotide analogs. That's all I have to say. Thank you.
Thanks, Tony. Good morning. I would like to join Bill in thanking everyone for coming this morning, and it's great to see a larger audience and a broader spectrum of specialties and interests. I've deliberately chosen to talk about abstracts and advances in liver disease that reflect themselves on our practices, on our everyday practices, as opposed to going into the more super specialized areas of hepatitis C treatment. I will say that based on the AASLD statistics, about a third of the meeting was pretty much related to hepatitis C. That would translate into about 2,000 abstracts and presentations, so there's no way I can realistically give you the full picture, but basically, just a little bit in terms of background, about 4 million Americans are believed to be infected with hepatitis C. It is estimated that by 2030, about $85 billion will be spent in healthcare expenses on hepatitis C. By then, it will be probably one of the top 5 most spent on conditions in the United States. We know that the percentage of patients with chronic hepatitis C progress to cirrhosis, and once you get cirrhosis, the annual risk of developing cancer is about 3 to 5%. This is by far the most common cause of liver transplantation in the United States, and as far as I know, the only viral infection that can be cured with medication. In order to understand this better, I think you have to look at the natural history of hepatitis C, and for those who are not very familiar, I think it's important to remember that even though hepatitis C is typically progresses to a chronic state, about 25% of patients actually spontaneously clear the infection. Those are typically patients who tend to be younger, more frequently female, but certainly not infrequently in your practices you will see patients who get acutely infected and then clear on their own. Nonetheless, in the 75% or so patients that do not clear, there are spectrums of disease that are affected to some extent by co-infection with HIV and alcohol intake. But overall, about 20% of patients progress to cirrhosis during their lifetime. And of those, some develop decompensated liver disease with the need for liver transplantation or, unfortunately, death. And some, as I said, about 3 to 5% per year progress to hepatocellular carcinoma, with the consequences, again, being either the need for liver transplantation, other therapies, or ultimately death. So clearly, this is a disease worth our attention. This is a condition that we need to focus on in our practices because it's fairly common, fairly treatable in a large majority of patients, and important to recognize. This is sort of a recurrent theme now. For the past 5 years, people have been looking at the future impact of hepatitis C in terms of the burden of cirrhosis, decompensated liver disease, hepatocellular carcinoma, and liver-related death. If you look at this table, we're around 2010. We're in 2011. You will see that the number of HCV infections shown in the first line will gradually decline over time. from 3 million in 2000 down to about 2 million in 2040. However, the number of patients who develop cirrhosis and decompensated liver disease will exponentially increase. And the number of cases of hepatocellular carcinoma will increase also. The burden of patients who will die from liver-related causes will increase almost threefold over the next 2 decades. So if you think you've seen the brunt of the hepatitis C epidemic, you have not. Over the next 20 to 30 years, we're going to have to deal with much more complications of hepatitis C than we ever thought we would need to. Hepatitis C, of course, is a curable illness. You can actually give patients medications, and in a certain percentage of them, and we'll go over that in a minute, they achieve what we call a sustained virological response. This is an undetectable hepatitis C viral load, typically after 24 weeks of stopping therapy. And in patients who achieve that, they're typically cured of the hepatitis C over 97% of the time. And so I'm going to repeat this term SVR, but basically what it means is the gold standard for cure for almost all clinical trials that are currently being done. I think the first and perhaps the most important issue, and where we're hopefully making advances in the next few years, is screening. If you do not know someone has hepatitis C, you can't treat them. So screening needs to be a focus, and this is a collective responsibility of both primary care physicians, gastroenterologists, hepatologists, and other people who potentially see patients who are infected. This is a synopsis of the CDC guidelines as they stand today, as to which patients should be screened for hepatitis C. And there are 2 categories. If you've been exposed, obviously, a healthcare or emergency personnel person, or a child born to an HCV-positive woman, that would be based on exposure. Or if you have an increased risk, and this includes intravenous drug use, certain high-risk groups from the days when we did not test for hepatitis C because we didn't know it existed, if someone was ever on a chronic hemodialysis, if they have evidence of chronic liver disease, and if they're HIV positive. This is what we use today to determine whether we order a hepatitis C antibody on somebody or not. Well, we know now very well that this does not work. The number of patients who have hepatitis C but are not aware of their diagnosis is estimated at about 75% of all patients. So even though we're making efforts to screen patients, these efforts have been acknowledged to be unsuccessful. So perhaps there is a new way of looking at this, and that's what many of the recent studies, including abstracts at AASLD, have focused on. If you look at the prevalence of hepatitis C based on age categories, or what we call birth cohorts, it becomes evidently clear based on insurance claims from patients that were tallied over the period of a year in 2008, that over 75% of patients, about 80% of patients, were born between 1945 and 1965. So if you actually look at all patients who have hepatitis C today, if you just narrow it down by age and test patients in that age category, you will likely pick up the overwhelming majority of patients. So that led people to actually think about how this would objectively be tested to see whether it has downstream benefits on patients. I will say that both studies that I'm going to cite on this are models. They're statistical models. It is practically impossible to do a study where you actually screen by age over time. It would cost billions, not millions, billions of dollars. But these models are statistically accurate and based on very good information. The first was initially reported at this year's DDW and is now published in last month Hepatology, for those who wish to read it. This basically breaks down the impact of birth cohort screening for hepatitis C compared to risk-based screening. And if you actually look at this model that compares the impact of screening by birth versus by risk factor in people born between 1946 and 70, and if you look at the impact of treatment on these patients, you will find, without getting into too much statistical detail, that if you use the birth cohort screening method, you would actually end up having 55,000 fewer cases of compensated cirrhosis, about 31,000 fewer cases of cancer, about 6,000 fewer cases of liver transplant, and potentially about 50,000 fewer deaths. That all looks great. But you would end up having more healthcare expenditures because you're now identifying more patients and treating them. Your expenditures would go up to about $80 billion just for screening versus about $54 billion. You would pay less cost in terms of treating advanced liver disease because you'd be treating it at an early stage. And you would have something called an ICER, which is an incremental cost effectiveness ratio, just a way of saying that you're actually advancing care in a cost effective manner of about $38,000 if you use the birth cohort approach versus risk-based screening. This is another abstract that chimes on the same thing that was presented at AASLD, published just a few days ago in the Annals of Internal Medicine, which basically looks at an even broader cohort from the National Health and Nutrition Examination Survey, looking at patients who were born between 1945 and 1965. Again, this is a statistical model that included about 67 million people. And if you basically look at that approach, the lifetime cost of treating the estimated 2.4 million people that you would test and would be positive, the illness-related lost productivity, and the increased loss of quality of life and other factors would lead to the following. You would end up spending more money to treat additional cases. This would be an increment of about $5.5 billion and an increment in quality of life, this ICER measure, of about $16,000. You would end up gaining an additional 500 and some thousand quality adjusted life years, which is a validated way of showing addition of survival with factoring quality in. But this would cost you about $19 billion. And your increment in cost effectiveness would be about $35,000 per quality adjusted life year saved. All of this is statistical lingo that tells you that it is cost effective to do this, even though it costs a lot of money. So my conclusions based on these two papers now, no longer abstracts, is that screening based on risk factors will miss many cases. Screening based on birth cohort, and the consensus seems to be 1945 to 1970. So any patient you see, if they're born between 1945 and 1970, you do not need to ask them about risk factors. You just order a hepatitis C antibody on them. You will pick up a lot more patients. They'll likely benefit from advances in treatment. This is more intuitive, makes more practical sense. Of course, there are no randomized studies that those would actually be implementing the policy and following it over time. But certainly the CDC has made pretty clear indications and signals that it is likely to amend its policy so that birth cohort screening becomes the recommended approach. So we're going to talk a little bit about treatments, but I think for the broader audience, one of the issues that come up very frequently, certainly in my practice, is the issue of milk thistle, silymarin, and whether milk thistle works, and if it works, should patients take it, and for how long. And for a long time, we really did not have any clear, objective answers to give to patients. So historically, we would tell patients it's okay to take milk thistle because we don't think it's harmful. Well, a few years ago, the government, the NIH and NCAAM, funded a study looking at the impact of milk thistle on liver enzymes in hepatitis C. It did so based on the knowledge that milk thistle is safe. It has antioxidant, anti-inflammatory properties. Up to 30% of patients with hepatitis C take it. 4 centers basically gave their patients who had an ALT greater than 65 a medication called Legalon, which is silymarin, at the dose of 420 or 700 milligrams administered 3 times daily. And there were basically 3 groups, those 2 doses plus a placebo group. The primary endpoint here was only a reduction in ALT less than 45. So understand that this does not include histology and does not include any objective measures of liver tissue improvement. They also monitored hepatitis C RNA-PCR because there's some thought that perhaps silymarin has some antiviral properties. The adherence to silymarin was excellent. Even in patients who had to take up to 15 pills per day, pretty much everybody took their full dose. So people have no problem taking silymarin. They did not appear to have any adverse events compared to placebo, but this does not appear to lower your liver enzymes. So if you actually look at all the patients that were in the study, there were only 6 participants and only 2 of them in each treatment group that met the primary endpoint of reducing their ALT. The mean decline in serum ALT activity overall was no different between the placebo group and the 2 treatment groups. So what does that tell us, and what are my conclusions? Oral milk thistle, even when given at high doses in a fairly purified manner, not what you buy at GNC or your local nutrition store, does not seem to be beneficial for hepatitis C infection. It is very well tolerated, but the cost is not trivial. If you go online and look at the Sideeffects preparations, they range between $50 to $75. My own personal take is to tell patients that they should not take milk thistle. If they absolutely insist they want to take it, they can, but I would not encourage any patient to take milk thistle at this point. Of course, the major criticism is this is not a study based on histology, which is the gold standard for treatment of liver disease, but I think we have enough data at this point so that it does not look optimistic. There are some additional results that are going to be available, but I don't think they change our recommendations dramatically. Moving on to more conventional therapy, last year we talked about 2 anticipated treatments that were going to become FDA approved for the treatment of hepatitis C. They have since then become commercially approved. They're boceprevir, which is given at the dose of 800 milligrams 3 times daily, and telaprevir, given at the dose of 750 milligrams 3 times daily, in combination with pegylated interferon and ribavirin. As you know, these treatments are approved for both treatment-naive patients, patients who have never experienced treatment before, as well as previous treatment failures. They can be given to patients who have compensated cirrhosis, and up to 50% or so of patients with both drugs, you can actually qualify for shortened duration of therapy. With one drug, you have to take with just food. With the other, you have to take with food that is not low in fat, but that's sort of a small difference. And last but not least, they're only approved for genotype 1 patients. So patients who have hepatitis C genotype 2, 3, 4, 5, 6 cannot take these medications. They're not FDA approved for them. And in the year that has, well, and not actually a year, in the 7 months that have gone since these drugs were approved, the AASLD has come up with new treatment guidelines that endorse the use of these drugs in combination with pegylated interferon and ribavirin. They also endorse, most importantly, that in the case of anemia, which is a frequent occurrence with both drugs, a key issue in management is with the reduction of ribavirin, and I will show you some data in a few minutes that indicates that this can be done without compromising the outcome very significantly. The AASLD guidelines also indicate that if somebody fails one protease inhibitor, they should not be retreated with the other, because we do not have data at this point that show us what will happen in that scenario. Both these drugs are called protease inhibitors. They affect the NS3/NS4 protease in the viral genome, and they clearly have an increment in sustained virological response, aka cure, compared to the previous treatment. So whereas almost 15 years ago the cure for hepatitis C did not exceed 10-15%, now we're looking at close to 70-75% with these agents. As I said, with potentially shorter duration of therapy and markedly improved outcomes even in previous treatment failures. So that is terrific. That's why you want to have your patients go through the time and effort and pain and suffering to actually take these medications, because they improve their likelihood of a cure. Now, unfortunately, additional better outcomes are not associated with simpler regimens or less complications. This is a non-exhaustive list of drug-drug interactions that occur with both boceprevir and telaprevir. There's really no easy way to do this other than to consult either the package insert or some web database that looks at drug-drug interactions, which is what I do. But very important for people out in practice to know that when they start medications, it's important to know if your patient is on a protease inhibitor and how the drugs may be adjusted, and contact their treaters accordingly. Of course, the previous generation of drugs, pegylated interferon and ribavirin, had their own slew of side effects of their own. Flu-like symptoms, anemia, rashes, dyspnea, et cetera. And now you're adding on top of that specific side effects or increments in side effects associated with protease inhibitors. So for boceprevir, the main side effects associated with this drug when given with pegylated interferon and ribavirin are anemia, neutropenia, and an altered taste sensation or dysgeusia. Notice that anemia occurs in up to 50% of patients in the boceprevir-containing arms compared to 30% just by taking peg and riba alone. Neutropenia more common, and dysgeusia, altered taste and sensation, more common. So not only side effects from the previous sort of backbone of therapy, but additional side effect with the protease inhibitor. The good news is that even though you get anemia with boceprevir, the cure rates, the SVR rates, appear to be even higher among patients who become anemic than non-anemic patients. And as seen in this table, which breaks down patients who had dose reductions, that's the RBVDR, and can't really point to it, patients who got epogen, patient who got neither, and patient who got both, there really is not much of a difference in the sustained virological response. So if you have a patient on treatment and they become anemic, ribavirin dose reduction is the way to go. There is no doubt in anybody's mind about that at this point. The other drug, telaprevir, that was approved at the same time also has its own share of potential incremental side effects. Rash occurs in about half of patients compared, again, to about a third of patients who just take peg interferon and ribavirin. Anemia occurs in about 36% of patients, and anorectal symptoms, primarily pruritus and discomfort at the time of defecation, occur in about 29% of patients. And if one again looks at the management of anemia in patients who take telaprevir, it appears based on these two tables that look at ribavirin dose reductions in patients who took the drug plus pegylated interferon and ribavirin versus no ribavirin dose reduction, it appears that neither anemia nor ribavirin dose reductions were associated with a lower SVR. So again, with telaprevir, if you experience anemia, ribavirin dose reduction is a reasonable way to go that preserves a decent outcome for your patient. Now, overall, the reason why I'm harping on anemia is because in the era of first-generation protease inhibitor, anemia is clearly the Achilles heel of therapy. This is what will potentially cause patients serious adverse events and may threaten their ability to stay on therapy. And with both drugs, boceprevir and telaprevir, and granted in the studies with boceprevir, patients were allowed to use growth factors. With telaprevir, they were not. So these are not by no means head-to-head comparisons. A high percentage of patients had anemia with a hemoglobin less than 10. A significant percentage in the boceprevir arms had to undergo ESA therapy. And up to 3% of anemic patients in the boceprevir trials required blood transfusions versus about 12% of anemic patients who dropped their hemoglobin less than 10 in the telaprevir studies. So these are data that show you very clearly that you have to manage anemia effectively, you have to manage it aggressively, and you have to be prepared for it if you are going to use the first-line protease inhibitors. And in fact, here I've summarized some of the guidelines that I think all of us could go by so that we can navigate patients successfully through treatment. Again, ribavirin dose reduction plus or minus growth factors. Even though we want to prevent blood transfusion at any cost, that's never a good thing. That may be necessary at times. Anemia management is critical so that patients do not discontinue therapy. The general background is that once you discontinue a protease inhibitor, you should not restart it if it's been discontinued for a significant period of time. You cannot dose reduce a protease inhibitor because that does not lead to a good outcome. And I think you should spend the time and effort, you or your nurse practitioners, PAs, and other support staff, spend time and effort to discuss with patients the side effects of therapy, educate them about what could potentially happen so that you can identify them and prevent them. And I think for the primary care physician or internist, calling the treater, whoever that is, hepatologist, gastroenterologist, before making any changes in hepatitis C medications should be the way to go. A few words about goals of future treatments. That was the bulk of the meeting. So The goals of treatment obviously are to find more effective treatments, shorter treatments, simpler treatments, less pills, less frequent, and less toxic treatments, which basically means drop the interferon and see if you can get away with it. And clearly, and this is a summary of about, I think, 30 abstracts, the drugs that are coming along, we don't know when, will at minimum preserve the efficacy of the first generation protease inhibitors. So I do not anticipate that any drugs will become FDA approved if they actually have an SVR less than what we get right now with boceprevir and telaprevir. And this is a list of these drugs. You don't have to remember any of them. None of them may make it to market for all we know. But basically, they all have comparable or superior efficacy in terms of patients who have genotype 1 and their SVR. In the small studies that have been done, which again have not, for these drugs, reached phase 3 trials yet. The other issue that I think is critical is trying to give patients the drug less frequently. And as you can see, the bulk of agents that are being developed are either a once a day or twice a day regimen. And so clearly over time, we will need to have drugs that are administered less frequently, and there's plenty of them in development. And ultimately, the holy grail of hepatitis C therapy is to drop interferon and basically do an all-oral regimen. And I'm not a big fan of sensationalism, but the sensation of this meeting was a small presentation, an oral presentation, where a drug called PSI 7977, which is a nucleotide analog, when given with ribavirin alone, not for genotype 1. Genotype 1 is what we talked about all along, the more difficult to treat genotype, but rather for genotypes 2 and 3. This drug, when given for 12 weeks with ribavirin and for different periods of time with pegylated interferon, either 12 weeks, 8 weeks, 4 weeks, or no interferon, in about 10 patients in each group, led to a 100% SVR in all groups, including the 10 patients that got no interferon. So that basically is at least proof of concept that patients can be cured of hepatitis C without the need for interferon, and obviously a lot more work needs to be done. So I'm not a big fan of speculation, but if you read the Wall Street Journal, the New York Times, you'll know that somebody thinks this actually is of value because the company that makes this drug was purchased by Gilead Sciences for $11 billion at a 90% premium. So there's a lot of money going into this. There's a lot of uncertainty, but certainly there are a lot of hope. There's a lot of hope for patients with hepatitis C in the future. I'm going to conclude by going over the following. I think you cannot treat patients if you don't diagnose them. I think birth cohort screening is going to be the way of the future. Certainly, I would start implementing that in my practice. Patient autonomy is important, but milk thistle probably isn't. So I would not encourage patients to take milk thistle at this point. Treatment is currently more effective and complicated, but will eventually get easier. And I think during this transitional period, communication between the PCP and the treater is very important. And new HCV treatment is a very fast-moving target, but approval of new agents may or may not be. We don't know when these new agents will be approved, so we have to make do with what we have right now. Thank you for your attention.